Hello friends, this is Dr. Sushanta Bhanja, your Pediatrics Super Specialty Faculty of Atoms Learning. Now, I am going to discuss the recent year question of 2023 on pediatrics. Before I will go for the discussion, there is a disclaimer. What is this? The question of this discussion on pediatrics are based on the topics that has been asked in the recent exam, and any resemblance to them is purely coincidence and by chance. So let's start. The first question, it was asked on brain tumor. So brain tumor is the important topic in NEET-SS. So the first question about the craniopharyngioma, which one is correct? Chemotherapy is the treatment of choice. Papillary craniopharyngioma subgroup is a common type in children. Children with craniopharyngioma often present with endocrinological abnormality, and distant metastasis is common. Now see that one by one. The chemotherapy is not a treatment of choice, it is the treatment of choice is surgery. Papillary subgroup is common in children, no. The papillary subgroup is common in adult, okay. And children with CP most commonly present with endocrinal abnormality or visual abnormality. So this is correct. And distant metastasis is not common in craniopharyngioma. Okay, so the answer is C. So let's see the important topic, that is the craniopharyngioma. What are the questions asked? So the craniopharyngioma is the most common supratentorial tumor in children, above tentorium cerebrum. It accounts for 7 to 10% of total childhood tumor, and the most common subtype, that is the adamantinomas metastasis, that due to the CTNNB1 mutation, that is adamantinomatous, and the gene is mutation of the CTNNB1. So in children, so A comes first, then P, so adamantinomas in children, and that is papillary variant is common in adult. So papillary is common in adult. So you remember A comes first in. So adamantinomatous is the commonest variant in children. But in adult, the BRAF6, that is B600E mutation is common. That is the papillary variant. Okay. And it arises from another implico, that is the Rathke's pouch. Okay, and it is minimally invasive. So it is minimally invasive. So distant metastasis is not common. Now, so this is written in nation. Now the clinical feature, there is two peak. First peak around 5 to 10 years, and second peak around 50 to 60 years, and often presents with endocrinal abnormality like growth failure and delayed sexual maturity, and visual change, that is decreased acuity and field of vision. Okay, so this is very, very important. So the child may present with bitemporal hemianopia. So these are the clinical features. Now the investigation, the CT scan, that is suprasellar calcification. The question is asked, suprasellar calcification is found in craniopharyngioma, and craniopharyngioma is a grade WHO grade 1. Okay, and in the MRI, so suprasellar calcification found in 90% cases. Now MRI, there will be cystic structure containing fluid of intermediate density. So this is the MRI finding showing the cystic craniopharyngioma, that is cystic structure containing fluid of intermediate density. So this is the CT finding, and this is the MRI finding. Now what is the treatment? Treatment is the primary treatment is the surgery, and chemotherapy has no role. So these are the questions asked. Chemotherapy has no role. Treatment of choice is surgery. Endocrinal abnormality is most common presentation, and there is a adamantinomatous type is most common type in children. Okay, and there will be suprasellar calcification also. This is all about craniopharyngioma. Now moving to the next question. The increase of maternal serum alpha-fetoprotein level can be seen in all except. So MSAAP, that is alpha fetoprotein, increase in all except the twin gestation, yes, epidermolysis bullosa, yes, congenital nephrosis, yes, but trisomy, all the trisomy, the alpha fetoprotein decreases. So let's see what are the conditions that decreases alpha fetoprotein. So this is the line from the Cloharty. A low serum alpha fetoprotein level can seen in trisomy 21, 18 and 13. So answer is obvious, that is the trisomy 13. So other than trisomies, the overestimated gestational age, fetal wastage, maternal diabetes and maternal obesity all are the cause of the reduced AFP. And increased AFP seen in multiple gestation like twin gestations, underestimated gestational age, maternal low BMI, neural tube defect, abdominal wall defect, and intestinal obstruction, renal condition like congenital nephrosis, skin condition like aplasia cutis and that is epidermolysis bullosa, fetal-maternal hemorrhage, sacrococcygeal teratoma, osteogenesis imperfecta. So this is very important question. So it will be helpful for INISS also. That's it. So reduced alpha fetoprotein seen in trisomies, fetal wastage, diabetes and obesity. Okay. So moving to the next question. A very important question. Every time they are giving one question from this neonatal cholestasis syndrome and with different clinical questionnaire. So this one they have given a 7-week-old infant under evaluation of cholestasis. Examination reveals triangular faces, broad forehead, deep-set eyes, prominent ears, straight nose with bulbous tip, pointed chin. And echo shows the peripheral pulmonary artery stenosis, and the eye there is embryotoxin, posterior embryotoxin. So what is the most likely diagnosis? So it is obvious posterior embryotoxin along with cholestasis with pulmonary stenosis. So it is nothing but Ehlers-Danlos syndrome. So Ehlers-Danlos syndrome. Here the Zellweger syndrome and all are the differential diagnosis. So we should remember that if there is hand edema with lymphedema with cholestasis means Ehlers-Danlos syndrome. Okay, so let's see the syndromes. Ehlers-Danlos syndrome. So it is the most common syndrome of intrahepatic bile duct paucity. It is due to the JAK1 gene mutations and chromosome is 20 and is mostly autosomal dominant. Now, here the presentation is neonatal cholestasis, dysmorphic faces, that is triangular faces, congenital heart disease, most common is pulmonary stenosis and it is peripheral pulmonary stenosis. And the congenital, the cyanotic heart disease is top. So both were asked in previous exam, what are the congenital heart disease seen in Ehlers-Danlos syndrome. Vertebral anomaly is butterfly vertebra. And in the eye there is a posterior embryotoxin. So these all are features of Ehlers-Danlos syndrome. Now other syndrome, that is the agonist syndrome, that is the episodic cholestasis along with lymphedema is agonist syndrome. Now Zellweger syndrome, it is the autosomal recessive disorder, so paroxysmal disorder, and there will be generalized hypotonia and looks like downs like features, and there will be abnormal head shape with calcification of the patella and greater trochanter, not the lesser trochanter. So this was asked in previous NEET-SS. So the greater trochanter and calcification of the patella is a feature of Zellweger syndrome. A neonatal iron storage disease, that is the neonatal hemochromatosis. There will be buccal mucosa biopsy or MRI demonstrate extrahepatic cirrhosis. So these are all the cholestasis syndrome. Now, next question. The question was framed from the brain death. Okay, so EEG that demonstrate electrocerebral silence over how many minutes recording time supports the diagnosis of brain death. So the EEG, the electrocerebral silence over more than 10 minutes, 30 minutes, 1 hour or 6 hours. So the answer is it is 30 minutes. It is written in Nelson. So it is the direct line from Nelson. Okay. So the brain death, the brain death is an irreversible cessation of all functions of brain, including the brainstem, and the time of the first, there are two examinations is required to complete clinical examination. The first clinical examination depends on the age of the baby. Less than 37 week in the preterm, this guideline is not followed. So the current guideline do not follow less than 37 week. So more than 37 week and less than 30 days in term baby. So the ideal timing the first ideal timing is the first timing of examination is the after 24 hours after birth or after CPR, and more than 30 days to up to 18 years after CPR, at least 24 hours after CPR. So these two guideline is very very important, but less than 37 weeks not required. Okay. Now there are three components, that is the irreversible coma and absent of brainstem reflex and apnea. So three components. So many time question will be asked whether the spinal cord reflex is present or not. So that is given in the except part. So all other component of brainstem, that is the component of brain death except this kind of question. So let's see the coma. Coma, the patient of unresponsive to noxious stimuli. And in this case, the posturing, the decerebrate and decorticate posturing are not consistent with brain death, and also the spinal cord reflex are acceptable reflex and not comes under brain death. Okay. Now the brain stem reflexes are absent. These are the pupillary reflex, corneal reflex, cough and gag reflex, oculovestibular reflex, and oculocephalic or dull side reflex. And apnea test. And apnea, the absence of respiratory efforts with a PSO2 more than 60 and more than 20 of the baseline is consistent with brain death. So after apnea test, if the PSO2 more than 60 and more than 20 from the baseline, then it is consistent with brain death. Now there are two ancillary studies, that is one is EEG and another is radionuclide cerebral blood flow studies. This is not necessary for that clinical examinations like this component, three component, coma, brainstem, and apnea. So these are not necessary. Ancillary studies are not necessary for the defining brain death, but it is ancillary study. So EEG demonstrates electrocerebral silence over a 30-minute recording time supports the diagnosis of brain death. So this was asked in exam. And the radionuclide blood flow studies, absence of uptake in brain demonstrates the absence of blood flow and is supportive of brain death. Clear? Now, next. What is the most frequent lesion associated with neurofibromatosis? 1. It is 1, not 2. So the most frequent CNS lesions, that is the tumor, is the optic nerve glioma. Okay, and it is a type 2. It is most common in type 2 neurofibromatosis, and this is a type 1 neurofibromatosis. So optic nerve glioma is the most common lesion associated with NF1. Okay. So glioma is the most frequently observed in CNS NF1. 5 to 2% of individuals with NF1, but 30% are asymptomatic. And the manifest as visual acuity, change in the visual field, and pallor of the optic disc. So this is the optic nerve glioma. The extension into the that is the hypothalamus leads to the precocious puberty. Okay, that's why that all children with NF1 undergo at least annual ophthalmological examination. So most frequent lesion is in NF1 is optic nerve glioma. On to the next question. The 48 hours term newborn developed increased work of breathing. There is tachypnea upper and middle lobe atelectasis with dextrocardia. The dextrocardia was not given basically. The image was given. So image was this is dextrocardia. So dextrocardia with breathing problem, most likely diagnosis will be it is not TTNB, it is not pneumonia, it is not HMD, it is primary ciliary dyskinesia or carcinoid syndrome. So dextrocardia with that is the immotile ciliary syndrome or carcinoid syndrome. Okay, so here the features are abnormal embryo, that is the monociliary embryo leads to situs inversus. So this is the dextrocardia means the situs inversus. Okay, and impaired cilia of the respiratory epithelium leads to chronic sinusitis, rhinitis, and bronchiectasis and pneumonia. And impaired cilia in the auditory canal leads to the recurrent chronic otitis media. So impaired cilia in the oviduct non-motile leads to infertility in the male and decreased fertility in the females. And depending on the ependymoma, okay, leads to the hydrocephalus. Okay, so here the triad is bronchiectasis, otitis chronic, sinusitis, and situs inversus. Okay, so bronchiectasis, otitis media, and situs inversus. So this is nothing but the primary ciliary dyskinesia. The answer is primary ciliary dyskinesia. Now to the next question. A 5-year-old child presents with steatoria, failure to thrive, ataxia, peripheral neuritis, retinosis pigmentosa. Blood smear shows acanthocytosis, and serum chemistry reveals decreased level of cholesterol and triglycerides and absence beta lipoprotein. The most likely diagnosis. So it is very simple. The acanthocytosis with steatoria and failure to thrive with ataxia, that means beta lipoproteinemia. Okay, so here the beta lipoproteinemia, Weiss disease. So in the introduction, it is an autosomal recessive condition, and it is due to the mutation of the MTTP gene. And in the childhood, the child presents with steatoria, failure to thrive, and abdomen is distended. DTR is absent because of the peripheral neuropathy secondary to vitamin E deficiency. So this is a feature of childhood. In the late childhood, the child may present with ataxia, retinitis pigmentosa, peripheral neuritis, and the posterior column lesions like picture like the abnormality, the position, vibration sense, muscle weakness, and intellectual disability. The differentiating feature from feverish ataxia is the suggested by presence of malabsorption, and acanthocytosis is present in the beta lipoproteinemia. Now the investigations, there will be acanthocytes and decreased level of cholesterol and triglyceride with absent beta lipoprotein and marked triglyceride accumulation in the villus enterocytes. And the mutation study, MTTP gene. So this is the credited, that is the speculated red blood cell. This is the speculated red blood cell is found in acanthocytosis. Now the treatment, it is the nutritional supplements of the fat soluble vitamins. What are these? A, D, E, K. So a high dose of E is given, that is the 100 to 200 milligram per kg per 24 hours is given. It arrests the neurological and the ocular, that is retinosis pigmentosa also, retinal degeneration, and limiting the long chain fatty intake can alleviate the intestinal symptoms, and medium chain, that is MCT, can be used to supplement the fat intake. So MCT can be used, but limiting the long chain fat is important. So the question will be asked, what are the treatment of beta lipoproteinemia except, so you can write. Now next, another clinical case scenario. A 25-month-old was admitted hospital because of stool that are pale, foul-smelling, and bulky with short stature. So it is one kind of, that is the pancreatic insufficiency. At the age of 3 months, thus presented with convulsion neutropenia. Since then, she has had frequent pudendal otitis, pneumonia. She has angular stomatitis, dental caries. The result of laboratory study was hemoglobin was decreased, leukocytes neutropenia with platelet count is decreased. So on the following most likely diagnosis, so it is, so platelet was around 1 lakh. Okay, it was 1 lakh, So it is nothing but it is pancreatic insufficiency along with pancytopenia, neutropenia with recurrent purulent otitis media, nothing but Soman-Diamond syndrome. Okay. So what are the features of the Soman-Diamond syndrome? It is an autosomal recessive condition. It is the mutation of the SBDS gene. Other than the SBDS gene, there will be DNA J sheet 21 gene and EFL1 gene. Chromosome is 7 and it is a ribosomopathy depending the ribosome assembly. So ribosomopathy, one example Soman-Diamond syndrome. Now the clinical feature, that is the pancreatic insufficiency. So there is stools are pale, foul smelling and bulky. There will be neutropenia. There will be skeletal abnormality like metaphyseal dysostosis, failure to thrive and short stature. Okay, and there may be hepatomegaly and dental abnormalities found. Also, there is a intellectual disability also. Now, in the investigations, there will be decreased serum triglyceride and serum that is cholesterol. Sorry, there will be reduced age-adjusted serum trypsinogen and pancreatic amylase level. CT scan shows the typical size and shape, but it is highly fatty. There will be neutropenia in 70%, anemia in 40 to 60%, thrombocytopenia 40 to 60%, pancytopenia 21 to 40%. And mutational study of the 3 gene SBDS, DNACG21 and EFL1 are defective. Now, what is the treatment? Treatment is the malabsorption, that is the pancreatic replacement therapy is given. But after correction, malabsorption poor growth commonly continues, and daily subcutaneous GCSF is given for the neutropenic patients, and only curative options for with if there is features of bone marrow failure, the bone marrow transplant is the only curative therapy. So this is all about the Soman-Diamond syndrome. Now, next, another questions, that is the about tumor lysis syndrome. So tumor lysis syndrome, all are previously it was asked kind of criteria. Now it is given what are the all are seen in tumor lysis syndrome except hyperkalemia, yes, hyperphosphatemia, yes, hyperuricemia, yes, hypercalcemia. No, it is hypocalcemia. All are hyper except calcium, that is the hypocalcemia is seen in tumor lysis syndrome. So answer is D. And what are the kind of criteria? There are two criteria, that is laboratory tumor lysis syndrome and clinical tumor lysis syndrome. So laboratory tumor lysis syndrome, at least more than is equal to 2 is required among these 4, and it is within 3 months of 3 days of the initiation of therapy and after 7 days of therapy, starting of therapy, the tumor lysis syndrome is observed. And there will be hyperkalemia more than 6, hyperuricemia more than 8, hyperphosphatemia more than 4.5, and hypocalcemia less than 7 milligram per dl. Okay, so this was previously asked, all are the component of Chiari-Bisscheff's criteria except. So hyperkalemia more than 6, hyperuricemia more than 8, hyperphosphatemia more than 4.5, and hypocalcemia. Now the clinical tumor lysis syndrome, that is the presence of laboratory tumor lysis syndrome plus more than is equal to one of the following. So what is this? Acute kidney injury, seizures and cardiac arrhythmia or sudden death. At least one more than is equal to 1 is required for the clinical tumor lysis syndrome. Okay, so this is all about the tumor lysis syndrome. The next question is, a 2.5-year-old healthy child suddenly develops a sore throat and fever. With a matter of hours, the patient appears toxic, swallowing is difficult with drooling, labored breathing, the neck is hyperextended and the child assumes tripod position. On X-ray there was thumb side. So this is typical. Which of the most likely diagnosis? So thumb side with toxic loop, with fever and respiratory distress. This is nothing but acute epiglottitis. Acute epiglottitis is mostly due to the most important it is due to H. influenzae and pneumococcal infections. So history there will be sudden drooling, muffling voice, fever, dysphagia. Okay, and sleeping dog position is there, and this is the thumb shine. Okay, the thumb shine appears in the epiglottitis. So this is nothing but epiglottitis. Answer is B. Okay.